Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Unicisive Therapeutics.
Hello, I'd like to welcome you all here today. We're going to be talking advancing hyperphosphatemia one dose at a time. I'm Stuart Sprague, Director of the Metabolic Bone Program at North Shore University, Endeavor Health, University of Chicago, and have over 35 years experience in treating and doing research in patients with hyperphosphatemia, bone, and kidney disease. Joining me today are Glenn Chertow, a professor of medicine, epidemiology, and population health and health policy at Stanford University School of Medicine. Dr. Chertow has conducted clinical research in kidney disease and bone and mineral metabolism over most of his 30-year career in nephrology. Also with us today is Dr. Pablo Pergola, who is Research Director of Renal Associates in San Antonio, Texas. He has significant experience treating patients with chronic kidney disease and hyperphosphatemia, has been involved in development of drugs, which include multiple phosphate binders, tenapanor, vitamin D analogs, and calcimimetics. Welcome, Glenn and Pablo.
Thank you.
Well, I'd like to set the stage here, and we're going to talk about the standard of therapy and how we're going to deal with patients with hyperphosphatemia and what the problem is that we have to deal with. Hyperphosphatemia is a major burden to our patients. You can see that the death rate or incidence of death actually goes up rather significantly once the serum phosphate concentration is greater than 6. And as the phosphate concentration reaches 9 or above, we have a doubling of the relative risk of death in our patients. As you can see on the figure to the right, as we get serum phosphate concentrations of 6 or so, we see a significant increase of hospitalization, both for cardiovascular hospitalization and all-cause hospitalization, which does progressively increase as serum phosphate concentrations approach greater than 9. Well, how do we deal with hyperphosphatemia in our patients with chronic kidney disease? Obviously, we do dialysis, but again, we don't have great control. So we have been using oral phosphate binders in conjunction with dietary phosphate restriction. Although phosphate binders reduce serum phosphate in these patients, it's not known if they really improve clinical outcomes. And we know we're not achieving optimal phosphate controls. We do have calcium-based binders that are frequently used, but there remains considerable concern regarding vascular calcification in the use of these binders. We also have had aluminum binders. However, that use is limited by the potential of aluminum accumulation, which may lead to osteomalacia as well as other effects from aluminum overload. In terms of the non-calcium-based binders, we have sevelamer hydrochloride, lanthanum carbonate, ferric citrate, sucroferric oxyhydroxide, and they can effectively lower serum phosphate without a known risk for vascular calcification. Ferric citrate offers the additional potential of increasing serum iron and may alleviate some of the need for IV iron. However, we have to be concerned about adverse events, which are predominantly gastrointestinal, which could vary from constipation to diarrhea and other issues. Well, pill burden seems to be a major problem. The daily pill burden on maintenance dialysis among patients is really the highest. Patients have a median of 19 pills per day. About half of that pill burden is derived from phosphate binders, and we have to remember these patients have to take these binders with each meal, which makes that even more difficult. This high pill burden is associated with lower quality of health for these patients, and we know that self-reportedly 62% of the patients are not adherent. We don't know about those patients who don't really admit to their non-adherence, how many of those are not compliant on a regular basis. Well, we do need new drugs to help us treat hyperphosphatemia. We have 6 approved phosphate binders, and as you can see, we have a rather significant rate of serum phosphate levels above our guidelines. If we look at serum phosphate levels greater than 5.5, we have about 44% of our patients are unable to achieve this during a 3-month average. And if we look at normal phosphate levels or above 4.5, we see that 75% of our patients are unable to control that serum phosphate over a 3-month period. Well, I would like to now shift and ask our partners for their opinions in our care of these patients.
Maybe I'll chime in here, Dr. Sprague. Thank you for that excellent summary. I'm 100% in agreement with you. The phosphate binders we have are helpful, but they're not getting us to where we want our patients to be. And the burden we place on those patients with respect to the number of pills or the frequency of ingesting the pills and the challenges they face with dietary phosphate restriction, all on top of the burden of dialysis, is really something. So I'm with you that if we can get therapies either in combination with phosphate binders or instead of some of the burden of the phosphate binders, that would be a tremendous advance medically and from a patient-centered quality of life perspective.
And if I may add a comment too, I think one of the challenges that we all face when treating our patients is that is GI side effects that you mentioned, particularly abdominal bloating, nausea, do interfere with the patient's ability to take sufficient nourishing, meet the challenges of maintaining albumin, for example, in dialysis and PD patients. So if we could find alternatives that had a better side effect profile, that would greatly aid in maintaining the nutritional status of the patients as well.
Well, thank you both. I guess I would like to emphasize what's been my experience is that hyperphosphatemia is basically asymptomatic for patients. They don't realize it, yet the burden of phosphate patients bothers them on a daily basis, which makes it very hard for them to follow what's going on. We really need something that's much more tolerable for patients to be able to take and maintain, as well as add to the effectiveness of what we already have.
I think I have the privilege of delving a little bit more deeply into some of the mechanisms of hyperphosphatemia. And I would just like to highlight the sources of phosphate that affect our patients and the means by which dietary phosphate or intestinal phosphate, perhaps better stated, is absorbed. So dietary phosphate is the major source of phosphate that results in hyperphosphatemia, although we shouldn't forget the fact that there can be endogenous sources of hyperphosphatemia. For instance, in individuals with very severe secondary hyperparathyroidism, there can be phosphate release from bone. And so attempting to correct endogenous hyperphosphatemia, that is phosphate that is coming into the bloodstream by high turnover bone disease, phosphate binders or therapies that impede the absorption of phosphate won't work. So in addition to thinking about phosphate removal with dialysis and dietary restriction of phosphate, we also have to be mindful to ensure that secondary hyperparathyroidism is adequately controlled. Once that issue is taken out of the equation and we see that people are receiving regular, sufficient dialysis to optimize their solute control, we still find that most patients on both hemodialysis and peritoneal dialysis have hyperphosphatemia. And so addressing the dietary phosphate becomes paramount. Now, as Dr. Pergola pointed out, our patients ought to be eating a diet that allows them to maintain nutritional status, and that includes dietary sources of phosphate. Proteins that we commonly ingest are important sources of dietary phosphate, and we certainly don't want to restrict dietary protein intake excessively in our patients who are prone to malnutrition. Although we should be mindful that there are preservatives and food additives that can increase phosphate intake. And so I often will remind our patients to eat well, and as blanking on the author's name, but the author who said, eat food, not too much, mostly plants. When we say eat food, don't eat junk. Ultra-processed foods increase the amount of inorganic phosphates that are absorbed and can be really problematic. Once the phosphates are ingested, there are two methods by which they are absorbed. One is through an active absorption pathway, what is sometimes referred to as transcellular absorption, and another pathway, which is actually the primary pathway, passive form of absorption that's paracellular. Fairly recent research has highlighted the fact that this paracellular pathway is the predominant source of absorption and is unsaturable. That is, the more phosphate that's in the intestine, the more that is absorbed. And then just finally to touch on, in addition to processed foods and additives, there can be pharmaceutical sources of phosphate. And for some of our commonly prescribed medications, you can see moderate amounts of phosphate and very different amounts of phosphate depending on which manufacturer is producing the excipients along with the active drug in a tablet or capsule. And I don't know if Doctors Pergola or Sprague have any additional comments on this issue of phosphate sources in the diet or drugs or preservatives, etc.
Unfortunately, we don't know how much phosphate's added to the foods, and that's been a real problem. So we're always guesstimating, and my guess is we're totally underestimating the amount of phosphate in the inorganic phosphate, which is probably more readily absorbed than the organic phosphate that's got to be broken down as you reprocess the foods. So this is a real problem.
Unfortunately, for many of our patients, the access to the more natural organic products that we would want them to eat is limited. So as much as we would want them to not eat the less ideal food, the junk food, if you might, that may be the only opportunity they have to maintain some adequate nutrition. So that is a challenge, but it's the reality for many of our patients. So the phosphate binders certainly will have to kind of fill in there to try to help them deal with that excessive load of phosphate.
Thank you both for those comments. I think the comments you make, Pablo, with respect to food availability is a major issue, as I'm sure most of our viewers are familiar. The end-stage kidney disease population is disproportionately from disadvantaged groups who don't typically have access to the fresh and non-processed foods that we'd recommend them to eat. So this is a really important point. And hopefully, as time goes on, through education and other programs, the diet can be an injurious problem for hyperphosphatemia for many of our patients. Meanwhile, the slide I currently have up really looks at the historic view of phosphate-lowering therapies, which date back to the 1960s, really with advent of aluminum, which was still being used during my training in the late 1980s and early 1990s. It wasn't until the mid-1980s and thereafter that it was recognized that calcium could function as an effective phosphate binder. And moreover, if the serum calcium concentrations were increased with intake of calcium-based binders, as well as with vitamin D, calcitriol, and eventually vitamin D analogs, that could help to control the severity of hyperparathyroidism. Unfortunately, what we subsequently learned, though, that was a logical strategy to undertake to control hyperphosphatemia and secondary hyperparathyroidism. What was the result was we were correcting the impaired intestinal absorption of phosphate with calcitriol or some of the active vitamin D analogs, and then delivering large amounts of calcium into the diet through calcium-based phosphate binders, and there was no place for the calcium to go, and ineffective bone mineralization. And so we continue to see non-osseous deposition of calcium, that is dystrophic calcification, that developed particularly in the vasculature and in other organ systems. And that led us in the early 2000s to really focus on development of phosphate binders that were non-calcium containing. And a series of phosphate binders were developed, including sevelamer, initially sevelamer hydrochloride and later sevelamer carbonate, later lanthanum carbonate, and the iron-based binders, sucroferric oxyhydroxide and ferric citrate. And then we had multiple options for non-calcium-based and non-aluminum-based binders, still suffering with high pill burden, but perhaps providing different side effect profiles and less difficulty with hypercalcemia and calcium loading. It wasn't until much more recently that a new mechanism of action was elucidated, and that was with the drug tenapanor, a sodium hydrogen exchanger 3 inhibitor, which blocked the absorption of sodium through the intestine, but in so doing altered the chemistry of the intestinal epithelial cell in such a way that there were conformational changes altering this paracellular passive pathway. And Dr. Pergola was a key member of research teams that identified the safety and relative efficacy of tenapanor as a phosphate absorption inhibitor, not a phosphate binder. And I'm going to show you now just some of the relative potency of some of the binders by gram weight percent. And I think we've found that the iron and lanthanum-based phosphate binders are a bit more potent than the more commonly used calcium and sevelamer, but still require multiple tablets or capsules ingested per day. As I mentioned earlier, this is a schematic really summarizing the issues of intestinal intake, paracellular and transcellular phosphate absorption, and on the rightward panel, the strategies that we have to manage hyperphosphatemia. I think the only thing missing from these cartoons is the issue of phosphate release from bone in the setting of severe hyperparathyroidism. Obviously, we can't correct that with phosphate binders or phosphate absorption inhibitors. There was a fair amount of excitement about possibly inhibiting active phosphate transport among the main active channels, something called NAPB2B, or sodium phosphate channel in the intestines. And it was identified that nicotinic acid and nicotinamide blocked this channel. Unfortunately, it turned out not to be as effective as hoped in several clinical trials. Tenapanor, on the other hand, was found to be both safe and relatively effective in lowering serum phosphate concentrations, initially discovered, if you will, by accident, because this agent was really developed initially for its properties of reducing sodium absorption. And in another formulation, it's approved for use in the setting of irritable bowel syndrome with constipation. But it was later discovered that phosphate absorption was reduced with tenapanor through conformational change in the intestinal epithelium. And we've seen a number of studies. Dr. Pergola was involved in many of them. And in the pivotal trials that led to the approval of tenapanor, that either as monotherapy or as in combination with phosphate binders, that it could effectively reduce serum phosphate concentrations with the effect of also softening the stool. There's a small fraction of patients, about 5%, who develop severe diarrhea, in which case, obviously, tenapanor should be stopped. In many of the other patients, softening of the stools is either tolerable or welcome, particularly for patients who suffer from constipation. And after the publication of several of the pivotal trials, we've seen more recently some additional studies really confirming the relative safety and efficacy of tenapanor. And this is another new short-term trial looking at patients with refractory hyperphosphatemia. And some of the primary endpoints you can see here on the left panel, mean serum phosphate concentrations over time, and mean changes in the right panel in parathyroid hormone and FGF23. So presumably through the mechanism of reducing hyperphosphatemia, we see other favorable effects on bone and mineral metabolism with the use of tenapanor. As through this summary, just to highlight the fact that from an adverse effect profile, the issue of significant diarrhea is rare, but softening of the stools is not. So when using tenapanor, I always remind my patients to stop any of their stool softeners or cathartics or laxatives or promotility agents, and basically allow the tenapanor to do its thing. Rarely will a patient require the lactulose or the linaclotide or senna or other laxatives that we often prescribe for them. And again, another relatively short-term trial, this one in China, which similarly showed improved efficacy when using tenapanor in addition to phosphate binders. So the advantage of having tenapanor, which in the US is approved for use in patients who have hyperphosphatemia refractory to phosphate binders or who are intolerant to phosphate binders, is that it can potentially improve control of hyperphosphatemia with a reduction in pill burden. And so I'll pass the baton on to Dr. Pergola to speak about another phosphate-lowering therapy on the horizon.
Thank you, Dr. Cherto, for that great summary. So, as Dr. Cherto mentioned a moment ago and highlighted the different potency of the phosphate binders available, the lanthanum preparations are among the most potent binders we have. They traditionally have been underutilized because they have a delivery problem. They come in big wafers that must be chewed in order for them to have adequate phosphate binding ability. And that is something that patients do not prefer, and it can increase the rates of nausea. Therefore, is not a preferred binder, but yet a potent one. So if you could change that property of lanthanum and make it and somehow much more friendly for the patient to use, then you might be able to deliver the potency of lanthanum without the side effects. And this is what oxylanthanum carbonate tries to do. It's a potent binder that shares the lanthanum binding capacity, but is delivered in a smaller tablet that is swallowed and is not chewed. The technology enhances surface area. It's released much more promptly after ingestion, and this enables smaller pills that are swallowed again. So this might help the patients with compliance and therefore, intuitively improve the efficacy of the medication. So in a recent presentation at the American Society of Nephrology meeting in 2024, Dr. Blog and others presented the effects of oxylanthanum carbonate in patients receiving maintenance hemodialysis with hyperphosphatemia. This trial was designed to look at the tolerability of oxylanthanum carbonate in patients receiving dialysis and have hyperphosphatemia treated with phosphate binders. And the idea was to look at tolerability in patients that had a clinically satisfactory control of phosphate, which is achieving phosphate levels of less than 5 milligrams per deciliter. Briefly, patients were eligible to enter the trial if they had a serum phosphate of between 4 and 7.5 milligrams per deciliter on phosphate binders. If the phosphate level after the screening period was over 5.5 and less than 7.5 milligrams per deciliter, they went to the titration phase. Otherwise, they went into a brief period of washout. During the titration period, patients' oxylanthanum carbonate dose was optimized to try to achieve a phosphate level of less than 5.5. Once those patients achieved that level, they were monitored during the 4-week maintenance period. And you can see that 41% of the patients in the green bar on the left side had phosphate levels between 5.5 and 7.5, so did not have ideal control coming in on their standard phosphate binders. That number of uncontrolled patients was reduced to 9% at the end of titration, resulting in 91% of the patients with a clinically meaningful decrease in phosphate levels, achieving levels less than 5.5. This was accomplished with a median dose of 1,500 milligrams of oxylanthanum carbonate, or 3 small 500 milligram tablets 3 times a day, with a small proportion of patients achieving this with even less medication. So oxylanthanum carbonate seems to be well tolerated, with adverse events that are similar to that seen with the other form of lanthanum and not dissimilar at all from other phosphate binders. So OLC enabled adequate control of serum phosphate in more than 90% of patients who entered the maintenance period. So this is a trial that I think it's provocative based on the tenapanor data that we saw from Dr. Cherto. It's intuitive to say, well, what would happen if we have a potent and effective phosphate binder associated with the transport inhibitor? And so you see here in this trial design in rats that different doses of OLC were combined with tenapanor. Caveat here is that OLC, the binder, was delivered in the food. So that would be the ideal delivery of binders, if you can mix it in with everything we eat, right? So keep that in mind. Tenapanor and OLC were effective at decreasing urinary phosphate excretion. In this model, phosphate excretion is a marker of absorption. If you can bind more from the gut, the animal will tend to retain more phosphate, and therefore urinary excretion decreases. But as you can see, the purple line shows the effect of tenapanor in combination with OLC, and one can clearly see that the effect was significantly more robust when the combination was provided rather than the individual agent. And so, again, this goes to potential opportunities to use combination therapy with tenapanor and other effective phosphamiders to help our patients with chronic hyperphosphatemia. The next step, as Dr. Charto alluded to, we have looked at nicotinamide as a most predominantly NaPi2b inhibitor, and the effect in patients on dialysis was limited. It was measurable, but it wasn't significant. The issue here, briefly, is that there are other transcellular transporters that may be upregulated in patients with chronic kidney disease. Therefore, if you block only one of the transcellular pathways, you may not get the full effect of blocking that pathway. So if you had an opportunity to use a broader blocker like EOS 789, this is a small study in animals in the middle panel there showing that this agent that blocks or the significant number of the transcellular transporters, then significant decreases in phosphate in these animals. So if you put this to the test in humans, have data from what is now called AP306, and there is a small trial on the use of these pancellular transport inhibitors might aid in the management of hyperphosphatemia. So we're awaiting these results, but as you can see, the number of tools available for the clinician to help our patients is increasing, and we're aiming at the broader spectrum of transcellular, paracellular blockade, and phosphate binding in the intestinal lumen at minimizing phosphate absorption to as much as we can possibly get to. Some of you are probably thinking, well, they haven't discussed dialysis. Certainly, the majority of patients are receiving twice weekly dialysis, and we know that was mentioned earlier, the effect of twice weekly dialysis on phosphate removal is limited and does not by any means, for most patients, for some patients it may be true, but for most patients equal the amount of phosphate that is delivered, and therefore our patients end up in a positive phosphate balance. So interestingly enough, we just recently saw the data on hemodiafiltration. It clearly showed improvements in mortality, hemoglobin levels, parathyroid levels, and quality of life, but no significant effects on average phosphate levels. We all know that extended dialysis, particularly nocturnal daily dialysis, are very effective at lowering phosphate levels. Unfortunately, they are not broadly used, and they're somewhat impractical and expensive. So although this could be a resource for most of our patients, this is not an option.
Well, thank you both, Dr. Chertow and Dr. Pergola, for those excellent summaries and overview of the issues. Clearly, we have challenges in managing this. I guess my question I would like to throw out, how do you approach a patient with what we have today that doesn't meet our goals, which again could be up to 3/4 of our patients, in terms of trying to get their phosphate under control?
I'll step in briefly and just share my thoughts. I usually tell our patients that it's very important to control their serum phosphate to protect not only their bones, but also their blood vessels and the rest of their body. It's a systemic problem. That is this problem of chronic kidney disease, mineral bone disorder, or CKD-MBD. And although we haven't solved the problem, and I think we're making incremental advances, we're at least at a point now where we have enough choices that we can select the right phosphate lowering therapy or therapies for the right patient. So for instance, if a patient is severely hypocalcemic because he or she is starting dialysis and is on loop diuretics, which promote urinary calcium loss, maybe calcium-based phosphate binders are a good choice, whereas for someone with no residual kidney function, we would want to stay away from them. If a patient has associated iron deficiency, the provision of ferric citrate might be a very good choice. If the patient is on peritoneal dialysis and dealing with constipation and not achieving control of hyperphosphatemia with a phosphate binder, the addition of tenapanor might be a good choice. So, akin to the way we manage patients with hypertension or hyperglycemia with diabetes, where we now have multiple choices for drugs, we can match the phosphate binder potency, the pill burden, and some of the positive and avoiding the negative adverse effects of individual drugs, and do a little bit more individualization of treatment than we have in the past. And I'm excited at the prospect of having new therapies available that might increase the potency, get more than 25% of our patients within target range, and moderate the burden to the patients.
If I can add to that, Glenn, this is excellent. I want to briefly comment on non-responders. In my experience of working through many binders and different agents, there are no non-responders. There are patients with individual challenges, and those challenges need to be discussed with the patients. We too often have too brief of a time with them and don't go in depth over what their circumstances are. And I do agree that we have multiple tools to help them alleviate some of the issues, may not all of them, but the nutritional aspect is important. What is the patient dealing with? Do they have anybody cooking for them? Do they have access to food? And what are they eating? The side effects of these drugs can be significant, but they're not all the same. So being able to use multiple different options, it's greatly improved over when we all started practicing, where we had barely 2 or 3 different agents and not much more to do. So I welcome the new therapies, and we will all need to be very proactive at looking at what different combinations of these agents might accomplish. But I think at the end, it's all going to be very patient focused, and not one therapy will fit them all. But the more options we have, the better chance it will have to get effective therapies to all.
I appreciate those comments. I would like to just add a little bit on what both you said. I do believe that we need to approach these patients relatively early before dialysis while they have CKD. We know that the other manifestations of CKD, MBD, hyperparathyroidism, increases of FGF23, which we didn't really talk about, that clearly has negative manifestations, develop early on. So I do believe that when patients have CKD and their serum phosphoruses are in the high 4s and clearly in the early 5s, we should be aggressive about treating them long before they get towards dialysis, because we could prevent the progression of these other issues, which also make hyperphosphatemia worse and harder to manage, as Dr. Chertow mentioned earlier, because the hyperparathyroidism, if that accelerates, you get phosphate leaching from bone. So I do think very early on, as Dr. Pergola mentioned, I want to give someone a not call them a non-responder. I think we have to individualize their therapy, and now we do have a myriad of treatments that we could do. Hopefully, the combination therapy, we'll get synergistic effects by using the sodium phosphate inhibitors as well as binders. And maybe if we develop blockers of the active transporters too within the GI tract, so we have 3 mechanisms that we could potentially attack, which may help us manage these patients as we move forward. But clearly, as was mentioned, I think patients have to be individualized. We just can't have a standard protocol and throw everybody in it, and that's it.
And the last quick comment, I think the issue of pill burden that you mentioned earlier is very critical to address. And, tenapanor is a small tablet twice a day that starts to kind of break into that pill burden. Other more effective binders, if they can be delivered in smaller tablets that are, more user-friendly, they may enhance the ability of our patients to comply with our therapy. So I'm intrigued by this new agents and how we can combine them with tenapanor and hopefully, like you said, transcellular phosphate inhibitors if they become available soon.
Any other comments from either of you as we try to wrap this session up?
Just that I enjoyed learning from both of you, and I hope our viewers learned something too.
I also appreciated the opportunity to present this with both of you. It's always a pleasure working together.
Yes, I would like to ditto that comment. I enjoy working with you, and we've interacted over many years in this very complicated area. I do want to thank the audience for sitting and listening to us. I do hope it was beneficial for you and for participating in this activity. I would like to ask you to answer the questions that follow this presentation and to complete the evaluation.